So I guess without further ado, I'm really pleased and really honoured to be able to introduce Professor Alastair Greystoke, who is a Professor of Precision Oncology, which is a very grand title, and I'm sure he will explain much more eloquently than I. So I'm going to hand over to Ali Greystoke, and it's all yours.
Thanks very much. Can you hear me okay? Yeah. Yeah, good. So thanks very much for coming along and listening to me in your lunchtime. I hope this will be helpful. I was asked to talk about circulating free DNA. So, and as I said, so I work as a medical oncologist up in Newcastle, for those of you who don't know me, but I'm also the clinical director for cancer for the Genomics Medicine Service. And of course, now is not sharing. Because now I'm not moving. There we go. Just some disclosures before we start. So what I'm hoping to do in the next 45 minutes or an hour is talk to you a little bit about circulating free DNA, what we mean by it, how it's measured, give you some thoughts as to what I think are good things about it, what are bad things about it, and then use how we can use it in patients first presenting with metastatic cancer. And I'm going to use lung cancer as an example because this is where it's coming forward very rapidly into NHS practice, but this could be exemplified to other cancer types going forward. At that point, I'll pause for a few minutes just to take any questions and to give myself a chance to have a drink of water. And then a very brief bit at the end of sort of some more emerging uses in terms of how we can use this to monitor patients responding to treatment and whether we can use it in the earlier stage settings, so patients first presenting with stage 1 to 3 cancer, and also looking forward, just starting to look at screening as well. So just to start off very basically from terminology, you'll hear people talking about circulating tumour DNA and also circulating free DNA. And so what's meant by those? So circulating free DNA is something that we all have. So going around our bloodstream, there will be small amounts of DNA in our blood. And in general, in a healthy person, that is being released by white blood cells, and it will be broken down and cleared from our circulation relatively rapidly. It's probably got a half-life in the circulation of only a few hours. If you have something abnormal in your body, so for example, if you're pregnant, sat here today, there will be some of the fetus's blood in your bloodstream circulating. And if you have cancer, particularly late stage cancer, you will almost certainly have a small amount of the tumour DNA in your circulation. So what we call circulating tumour DNA. So circulating tumour DNA is a subset of circulating free DNA. The question is, how does it get into the circulation? And we're not entirely sure. Is it because they're cancer cells that are dying and then being eaten by white blood cells that then die and release the tumour DNA into the blood? That's one explanation. Another is, if you look at my picture, you'll see that sometimes you can actually get cancer cells inserting themselves into the blood vessel walls, and maybe they're releasing it directly into the circulation from there. Maybe they're traveling around the circulation, and maybe it's a session for another day on circulating tumour cells, and maybe they're dying directly in the circulation and releasing their DNA. Or maybe they're actively excreting the DNA, maybe even as signals to other cancer cells and to the rest of the body. The short answer is we don't really know, but this is a well-described phenomenon. And the reason why it's important is that we can start to measure this, and that's because of improvements in the technology, so which has even over the last 10 to 20 years has got markedly more sensitive, to the point where we can reliably pick this up, certainly in the majority of patients that have metastatic lung cancer. And so what we're now trying to do is what's the best way of using it to go forward. So in the metastatic setting, particularly, you'll see at the bottom where it says systemic therapy, we're mainly using it at the moment as biomarkers to guide patients first presenting with cancer as to the best treatment. But you can see there's a number of different ways that we could use it, including monitoring for response, starting to look at how patients are becoming resistant to our treatments, and I'll touch a little bit on those. And then moving forward to the early stage setting, for example, looking for evidence of molecular residual disease and starting to guide decisions as to whether patients need adjuvant treatments or whether their cancer is progressing, and we can pick it up early following curative treatments such as radiotherapy or surgery. So the potential for these technologies is huge. So practicals. How does it actually work? Well, basically what happens is you take 2 tubes of blood from the patient. You can see that these tubes look relatively similar to the vacutator tubes in general. So you can just use your standard blood taking set, but they're not your standard tubes. So these ones are Streck, and there's a couple of other companies out there. And what those do is you may be able to see a little bit of liquid at the bottom, and that's preservative. Because as we talked about earlier, you've got your white blood cells traveling around the circulation, and they've got lots of DNA in. And if you just took it into an EDTA tube, which is what I used to do when I was first doing my PhD, if you leave it sat on the bench, or if you pot it in the post, those white cells will die, and they'll release huge amounts of DNA into your blood or your plasma, where you can't, where it will obscure any signal. So these are sort of revolutionized the field as well. So they contain this preservative that basically stops the white cells, it stabilizes them, stops them dumping all their DNA into the bloodstream or the plasma. And so you can take 2 tubes of blood, you package it up appropriately in a biohazard box, and you just pop it in the post office, and it goes to the laboratory. And we'll talk a little bit more about the laboratories that we use. And with those, they say it's stable for 72 to 96 hours. So you can actually ship these samples around the world to the laboratory of your choice, and maybe even a bit longer. So I guess the first thing is, can it detect all the abnormalities that we want to pick up in our cancer patients? So I'm afraid here you'll have to put up with my little PowerPoint drawings, but hopefully these are just to sort of give you an idea of how this works. So there you've got your plasma with all your copies of DNA. So actually it's very easy to pick up a mutation. Okay, and these, so I've marked those as red. So you've got 2 copies of abnormal DNA. You sequence those, and they show up as abnormal in your report. And I'll show you what the reports look like. So this technique, even at very low levels, very good at picking up mutations. However, amplifications can be a bit more challenging. You know, if you just look at that straight away, you might not spot the amplification until I put a little red circle around that. So that's then showing that there are multiple different copies of that same gene. So I'll take it back again so you can see it, and then it goes, okay. So picking up an amplification when you've only got small amounts of tumor DNA can be very challenging, because you're trying to see amplifications in tumor DNA that may only be present at very small levels. Similarly, trying to look for a deletion where you're looking for something not to be there can be very challenging, okay? Because again, we're looking at very low levels of tumor DNA. And similarly for fusions, you can see that there's this very small change in the DNA. Those can be challenging. So the first thing I wanted to highlight to you is that this technique is not equally good for picking up all cancer abnormalities. Very good for mutations, okay for amplifications. Deletions can be very challenging. Fusions, it'll depend on the fusion event that you're looking for. Now, obviously, the more tumor DNA that you have, the easier it is to pick up the amplification, because it's more obvious. And also it becomes easier to pick up the deletions than if you've only got very small amounts. So your ability to pick up abnormalities will also depend on how much tumor DNA there is circulating in the blood. So what's the minimum pickup? So the calculation I've nicked off my QBank, complete and utter plagiarism, but he says, well, he's right, that 3 picograms of DNA is about equivalent to a 1 whole genome equivalent. And in those 2 tubes of blood that you send away from the patient, on average, there'll be about 30 nanograms of blood. So that's about 10,000 molecules of whole genome equivalents. Okay, so that means if your patient only has 0.5% of their free DNA being tumor DNA, you can pick it up about 50 molecules. And that's probably about right. You know, if you try to go down any more, you start to get potential sequencing errors due to the amplification. You can start to get false positives. So in general, it's somewhere between 0.1 and 0.5% that you can pick up the tumor DNA. That's still pretty damn impressive to me. And partly all depend on context as well. You know, if you're seeing something that's very obviously associated with lung cancer, and it's a lung cancer patient, and you're seeing it at 0.2%, then you may accept that as valid. Okay, so there's no exact cutoff, but somewhere around the 0.1 to 0.5% is probably right. Once it's much more than 0.5%, you can be pretty sure that is likely to be a realistic result. So what do the reports look like? Well, this is a very busy slide. I hate it when people say that. I shouldn't have made it a busy slide. But this just gives you examples of a couple of different reports. On the top, you've got two different companies. You've got Foundation Medicine and Guardant, who are the two main commercial companies in this area. And you can see they produce a nice little coloured graphic saying what genes abnormalities they're found on the side, so you can see the gene name, what the abnormality they're found, whether it's mutation, whether it's amplification or deletion, and they give you the nomenclature for that. And they also say VAF and a percent. Okay, and everyone gets very confused by that. Very crudely, that is the percent of the abnormality in the patient. Okay. So that if it's saying, we'll go down to the next one, which is a bit clearer, which is an NHS report, so you don't have any of your fancy colours. You can see the first variant is listed as P53, and it said it's there at 10%. So 10% of the DNA in that blood contains a P53 mutation and is likely going to be coming from that patient's cancer. Okay. So that takes a little bit of your head to get around, and you have to get used to seeing these reports because it's a bit different. And we'll talk about the fact that you can often see multiple abnormalities in one patient and how you could potentially use that. But it's just to get you a feel of what these reports actually look like when they come back to us. So one of the advantages of cfDNA is it gives us an up-to-date picture of the tumor DNA in that patient's circulation. And I just wanted to show you this as an example of how that can be useful to me as an oncologist. So this was a young woman, 35 years old. She had metastatic pancreatic cancer. And you can see at the bottom that she had a KRAS abnormality, which is very common in pancreatic cancers. You find that in pretty much all pancreatic cancers. It's got KRAS abnormality. And that's present in 15% of her DNA. Circulating at the time, which is quite a lot. Okay, so it's a good read. We know it fits in with the context it fits. You can also see above it that there's a pathogenic abnormality in BRCA1, and that's at 7.8%. Now, if we'd done this on the tumor, that we might have seen that there was slightly less BRCA1 in the tumor than in the KRAS, but in a 35-year-old young woman with pancreatic cancer, we would have been worried that this was a germline abnormality. Okay, that she'd inherited this, that she was a BRCA1 carrier, and would be referring her through to clinical genetics. We'd have to take the blood sample and send it off, and there'd be all this worry that she might have a germline abnormality, and what about her children? Because we could do this straight away, and I could see that actually this was probably just within her tumor. It's not 50%. If it was in her germline, it would be in 50% of her DNA because she would have inherited from her mother or father. So she hasn't inherited this. I can tell her straight away that this is not a germline abnormality. I do not need to refer this lady to cancer genetics. The next question is going to be, well, what about treating it? We know that BRCA1, it may predict for sensitivity to some tablets, PARP inhibitors, for example. What about giving this young lady a PARP inhibitor? I can say, well, yeah, it's present in the tumor. It's present probably in quite a lot of the tumor. It's worth a go, but it may not be present in all the tumor. So it may or may not work for you. Okay, so it gives me a very good up-to-date picture. I've got two different genes there, and I can even start to crudely look at the various proportions and also how much of her blood is being provided from the tumor, which maybe give me some idea whether it's inherited or not. It does lead to issues if you start to have about 50% of the tumor DNA in the blood being, 50% of your circulating DNA being from the tumor, because it can be difficult to determine if it's germline or not. But it does give an up-to-date picture. And as you'll see later on, we can start to map that and watch it coming and going as we give treatment. So who are the benefits? Who are the patients at the moment who might particularly benefit from this technique that is there and available? So, and I'll show you a case study of this. So patients where we can't do traditional biopsy because it's potentially dangerous, we just can't get through to the tumor, and that happens quite a lot in lung cancer. Equally, sometimes where there may be delays in trying to get a tissue biopsy because we have to do a special technique, or we have to do surgery, or a couple of times we've done it in lung cancer patients where they've been so unwell, they haven't been able to lie flat for a bronchoscopy. So we've done circulating tumor DNA instead. There's also a number of patients where we just don't get enough to do all the molecular analysis on, and it's insufficient. And for lung cancer, that's about 20 or 30%. I'm going to concentrate on lung cancer as an example. And lastly, as an emerging area, well, what about this? You know, we've identified our patient has a targetable abnormality. We've given them a tablet. It's worked for a period of time. The cancer's starting to become resistant. Can we work out how it's become resistant and either give them a new treatment, either through the NHS or through clinical trials? So the question then is if you've got this technique, you know, these are not cheap techniques. So the cost for the commercial companies is about £3,000. It's less than the NHS. Should we be doing it on all the patients? And in lung cancer, we've thought about this quite extensively. And there's a number of suggestions that people have thought about. So the first one is, if you go down on the right-hand side of the slide, it's what's called the plasma first approach. So your patients had their biopsy, potentially, maybe even not, as we'll talk about, and you send their blood away at the same time or beforehand to do genotyping. And that's your primary readout of your patient's genomics. The second way around is basically to say, well, actually, we've got the tumor biopsy. Let's go down the traditional approach, and we'll analyze this for the genes that we're interested in. And then you could either do it the complementary approach, which says, well, actually, we're going to do it in the tumor and the blood at the same time and try and get as much information as possible. I'll show you this, some example of that. Or no, actually, this is an expensive technique and we're only going to use it in those patients where our initial analysis fails, what's called the sequential approach. So I'll give you some examples of that, but there's 3 different ways that we could use this. We could either use it plasma first, patients walking through the door, and I'll talk about that. At the same time as the tumor goes off to the genomics lab for the analysis, complementary, or sequential, where we've already done it and there's either insufficient tumor or genes have failed, and where we're doing a backup analysis to try and make sure that we pick up all the patients with abnormalities. So, sorry, there's a bit of a lag. So this is the example of what's called the sequential approach. So this is using in patients who already had genomic testing done on their tumor. And so this was a big paper that presented 8,000 patients with lung cancer. And they found in about 20% of them, you can see 12888, that they didn't have a full genomic abnormality. And they said, well, can we what's the added back value here of doing a blood test? And then about a third, they said, well, actually, although we don't have a full profile, we've got a good driver, the patient's got an abnormality, we already know we're comfortable about that, we're not going to do the blood, that's fine. But in the rest of them, they went forward and they did blood analysis. And in an extra 250 patients, they found a treatable abnormality where we have treatments in the NHS, showing, and it was only about half where they didn't find something where they said, well, actually, no, this patient is genuinely negative for a biomarker. So this shows that you can identify about 20% of your patients that where your tumor analysis doesn't work for lung cancer, and a significant number of them you may then be able to do a blood test and still find a treatable abnormality for them. And that's probably the way that you would do it if you wanted to do your fewest number of blood tests. The next way is what's called the complementary approach. So this is saying at the same time that we diagnose the lung cancer on the tumor and send the tumor away to the genomics laboratory, we're going to send a blood sample off to the lab at the same time. And what I've shown here is the experience from the Marsden, where they did this in about 300 patients. And what they showed was that if you do this, you get your results on your blood back in about half the time to your tumor, and you get your patients, sorry, about a quarter of the time to your tumor, and you get your patients on treatment in about half the time. So you can speed up the time to get your patients' results, and also you can get them on treatment sooner. And they also showed, very similar to the last paper, that you can find something in about 20% extra patients, and that's well established. So it gives you quicker results and can give you extra information. But that means that every single patient, you're doing 2 separate tests on them. Is that the most cost-effective use of NHS resources? And so what we've been trying to do at the moment in the NHS for the last year or two, and what's been using up a lot of my time, is saying, well, actually, rather than waiting for the tumour or even, the biopsy and the pathologist to confirm lung cancer, it all going off for the predictive testing. What about trying to do this really upfront when the patient first presents with metastatic lung cancer? What about doing a blood test early on, looking at this plasma first approach? And can that help us guide patients' treatment, and can it get them on treatment sooner? And so just to show you why we think this might be helpful, so I'm just going to take you through the standard pathway of a patient presenting with cancer and show you how complex it is and how often things can go wrong. This should be easy, but it isn't. So patients have, a scan showing they've got malignancy. Somebody has to organise a biopsy. It has to go to the molecular laboratory, and then we have to get the results back. And that's 4 different teams involved to get that result back and the patient on appropriate treatment. And we all know that things can go wrong, that you can have a failed biopsy, the molecular analysis can fail. Particularly in our part of the world, we may need to organise some transport, and it may need to be integrated into the pathology report. And sometimes, unfortunately, the result goes back to the wrong person. So there's lots of reasons why this can go long on. And on average, at least in lung cancer at the moment, it's taking about a month for patients to get the results coming back. And we've got a big meeting with NHS England nationally in a couple of weeks' time to see what we can do to get this quicker, because this has significant consequences for the patient, not only in psychology. They're waiting for test results to get them on treatment, but also a number of these patients will be becoming less well and will never get to treatment or get the wrong treatment. So that's very different from the sort of plasma first approach, where your imaging shows malignancy. Your nurse takes the blood and sends it off in the post. It goes straight in the post to the molecular laboratory, and then we get the results emailed straight back to the dedicated end user and hopefully get the patient on treatment more quickly. So, as I said, we've been running a pilot for, since March 2022 within the NHS to look at that plasma first approach, and particularly to see whether, how beneficial this is and whether it's cost effective. And this is where it gets slightly confusing, because there's been 3 different phases of the project. In the first one, we only had 700 samples nationally, so we had 100 in the Northeast. And we were sending them off to a commercial company like Foundation Medicine or Guardant that I showed you earlier. And we had to give obligatory data back to NHSE about what happened to these patients, so we can help to try and work out whether it's and the resource use to work out whether this is a cost-effective use of resources in the NHS. That has then led on to phase 2, which is just coming to an end now, where there was 2,400 samples nationally, and again, where we have to give data back to the NHS. But rather than using a commercial company, this is now going down to the North Thames Genomic Laboratory Hub, where they're doing a tech transfer using one of the commercial companies. And then again, we do have to provide the data back. And then hopefully, as of April this year, it will go into a sort of fully commissioned service, 10,000 samples per annum, where we won't be required to provide data back. And we're hoping that that service will be provided by two of the genomic laboratory hubs, North Thames and another one using a tech transfer from a company. Just to show that this plasma first can approach this, can work. This is the French are well ahead of us. So they did this within a randomized trial, just compared to 150 patients, where they either had the blood first or the standard approach. I won't spend too much time on this. We can talk about it more in questions. But in brief, they showed that, particularly if you look at the time to treatment initiation for category 1 treatments, so these are identifying the patients where they've got a targetable abnormality, where you're giving them a tablet to get them on their first lung cancer treatment. You can see they brought down the average time for treatment from 37 to 21 days. Now, actually, that could have been much quicker, but many of the oncologists were quite conservative, and they wanted the full results back before they'd start treatment. So it could actually have been quicker than 21 days. So that's a lesson for us from the French as to how we need to do this going forward. We need to have funding for all our treatments for the first line on ctDNA, and we need to educate our clinicians that actually, if you found a decent profile, it's very valid to use that test to get your patient on treatment. And the cost effectiveness analysis is ongoing to work out which is best for the NHS in terms of, should we be going plasma first? Should we be going complementary? Should we be going sequential? But on the basis of that project, we were able to change NHS funding So this changed about 18 months ago now. So now NHSE will accept as valid a circulating free DNA result to put a patient on treatment. You do not need to wait for the pathology and the tumour result. Provided you're happy, the MDT is happy that this is lung cancer, you've got a valid result, you can treat the patient straight away. You just need to tick the right box. So that all sounds very worthy. I'm going to show you a case for how I've used this in my own practice and show you how this can be very useful. So this is a 72-year-old woman who's a never smoker, completely fit and well, and presented with dizziness and headaches. And I've highlighted there her head scan, where you can see on the red arrows that she had multiple brain metastasis with extensive swelling. And then she had a PET scan along with a CT scan to look for the primary site, and it was a lung cancer. But you can see, unfortunately, from the outside the brain, that, well, fortunately for her, but also unfortunately for trying to work out what was going on, there was only 3 little areas of tumour, and we could not easily get a needle into any of these. One of these was inside the lung behind the rib. One was a lymph node that we couldn't get to, and the bottom arrow was an adrenal gland, and she was all teed up to have a trans endoscopic biopsy through her stomach to get to the adrenal gland, because this is a lady who's a never smoker. We think she might very well have a targetable abnormality where I can give her a tablet. Fortunately, we did have access to circulating free DNA analysis, and you can see there that, that she had a classic mutation there. It says in 3.7% in EGFR, which is the most common abnormality in non-smoking related lung cancer. I have a tablet for that has a 70% chance of working, including in the brain. So we cancelled this lady's biopsy on the morning, and I gave her the tablet on the afternoon, and she responded beautifully for a couple of years. Unfortunately, these tablets don't cure our patients, and she had treatment with a tablet. She had radiotherapy to the chest, but then she was progressing. And this is her subsequent blood sample, so monitoring how this patient became resistant to treatment. And you can see there are far more abnormalities. The level of EGFR before, which was at 3.7%, is now 7.2%. So there's more tumour DNA in this lady's bloodstream. And you can see there's lots of different abnormalities, including in some abnormalities here that we often find in small cell lung cancer. And in fact, when I saw this, I was worried that her cancer was changing to small cell, which is a well-known phenomenon in response to treatments, that the cancer can actually change from a standard lung cancer to a small cell. And we were able to get a biopsy this time. The cancer got big enough that we could do it. And this showed that this indeed had transformed to small cell cancer. So this was very useful for this patient in terms of both starting up her first treatment, but also highlighting to me that her cancer was doing bad things that I needed to know about. That all sounds wonderful. Everyone gets very excited about cfDNA, but we do need to take it with a pinch of salt. This is a very sensitive test. It can be very specific, particularly if you've got decent amounts in the circulation. But it doesn't always change in response to therapy, and it doesn't always tell you exactly what's happening in the tumor, because DNA gets changed to RNA, gets changed to protein. So, you know, the DNA changes in a patient may not tell you exactly what's going on at the protein level. RNA is the next line down, and it can also be very sensitive, but it's less stable than DNA and far more difficult to analyze in the circulation. It gets broken down much more easily, but it is further down the track. And protein, unfortunately, whilst it tells us exactly what's going on in the tumor, often you can't do it on liquid biopsy unless you've got circulating tumor cells. And you normally need, you know, it takes a lot of workup. You need a different antibody for each protein. That's far more challenging. So we just need to be aware that by DNA, we're looking at something that's relatively upstream in the cancer's in the cancer's behavior. And it may not tell us everything about the cancer that we may not want to know, particularly when you're starting to think about, so for example, drugs targeting the immune system. It will not give you your PD-L1, which will tell you whether the protein, which is likely to tell you whether your cancer will respond to immunotherapy or not. It can't do that. The other thing is, I said that it is present in the vast majority of patients with cancer. And in lung cancer, it's about 80% of patients with metastatic lung cancer, but it is not all. And there's things that predict whether it is more likely for you to pick up the cancer or not. So the first is size. So in the bottom right, you can see that thing that says tumor volume centimeters cubed. So I talked to you about the 0.1%. I don't know if I've got a pointer here. I don't think I do. So the 0.1% is about equivalent to 10 centimeters cubed of tumor. So if your cancer is smaller than that, so for example, in the early stage, if it's 1 centimeter cubed, the predicted percentage in your blood is going to be 0.008% of your DNA in your blood is going to be from the tumour. You're not going to pick that up. Equally, we know that cancers in the lungs are very good sponges, and they will sop up stuff, including tumour DNA. So if your patient only has cancer in the lungs, you are less likely to pick it up. Equally, if your patient only has cancer in the brain, you're less likely to pick it up because of the blood-brain barrier. So how big the cancer is and where it is tells you how likely it is to pick it up, and you can get false negatives. And because you don't have tumour under the microscope, you don't know if it's a false negative or whether they just don't have an abnormality in the 10, 20, 300 genes that you've checked. So it's really challenging. The other thing is, unfortunately, as well as false negatives, you can get false positives. And I talked earlier about that white blood cells release DNA in your circulation, and that most of the DNA in us sitting here is from our white blood cells. Now, the problem is we are all getting older. And as we get older, our white cells get older as well. They're exposed to X-rays, they're exposed to carcinogens, poisons in our blood, reactive oxygen species. And unfortunately, they mutate as well. And as you get older, our white cells accumulate more and more mutations in them. And that you start to pick that up in the circulating free DNA. And so you can see on the right, as we get older, by the time you get to 70, the vast majority of us will have at least one mutation in our white blood cells that you may pick up in circulating free DNA. Now, what that means for our health, we don't know. There's this phenomenon for hematologists called clonal hematopoiesis of indeterminate potential, which this may or may not overlap with. But from a practical point of view, we will start to see some mutations, and you do, particularly at low levels. And unfortunately, some of these are genes that are related to cancer. So you just need to bear low-level results, particularly with certain key genes. DNMT3 is the most common one, but there are other genes that can be coming from your white blood cells rather than your tumour and give you a false positive. So I feel like I've talked quite a lot. So I'm going to just pause there and take, if anyone wants to ask me questions while I have a sip of water. And then I've got about another 5-10 minutes on emerging causes if we've got time.
So there's a couple of questions in the chat. So the first one is from Natasha. Natasha, I don't know whether you want me to read it out or you want to ask the question yourself.
Yeah, I can read it out. I'm a histopath trainee. I'm currently at a program doing a PhD in molecular pathology, but I work on lymphoma. Non-small cell lung cancer is always used as the poster child for ctDNA for good reason. We've got a lot of really good data for it. But what about other cancer types? I'm particularly interested in lymphoma and hematomalignancy stuff.
So as you said, lung cancer is the poster child, and the reason is that we've got 8 different abnormalities that we have treatments for in the NHS. And so that means about 30% of our patients will have treatments that we can offer them even in the NHS, never mind outside of trials, and we'll talk a little bit about trials in the next bit. And the other reason is actually our biopsies in lung cancer are often small and fail as well, and our patients are going off. So there's a reason why circulating tumour DNA has concentrated on lung cancer for both practical and actually therapeutic reasons. There is increasing interest in other areas, including particularly cancer of unknown primary, where we run into similar issues, pediatrics, and in lymphoma there is interest. Both there's you may be aware of the networks of excellence that are just launching. So there's liquid biopsy and a network of excellence and a hematology network of excellence, and both of them are interested in looking at circulating free DNA analysis in lymphoma. You'll be pleased to hear.
Fab, thank you very much.
Then we've got somebody with their hand up, but unfortunately I can't. We've only got one person with their hand up. I wondered if you could actually ask your question, because unfortunately I can't see the names.
Yeah,
so
sorry.
There you go, that's fine.
It's Pasquale here. I work with Ali actually in Newcastle. So, well, Ali, I mean, it was a pleasure to hear you, and I think it's better when I hear you from distance rather than cheers. Face to face. No, just joking. I mean, the model that Ali was presenting, I think it's perfect for lung cancer. Partially, Ali replied to my question already, but I think in other tumor types, it could be a bit more difficult to anticipate the ctDNA, to the point that it could become diagnostic. I mean, it's perfect when you know already the mutation that you want to go and check. The majority of the genes that are involved in lung cancer are small genes. The mutation are known, but there are other cancer, and of course, Ali knows, I think, about prostate cancer, where most of the alteration are other loss of big gene like P10 or BRCA2, or fusions like ERG-Tempress. So this might be a bit more difficult to use, at least for the diagnostic purpose. But definitely, I would say it's great to use in terms of tumor evolution and to find out emerging mutation, especially when patients are on treatment. So it was not actually a question; it was just a consideration. But I would be great to hear also from Ali what he thinks. Thank you.
Yeah, I think you're right, Pasquale. I think the number one thing is to say not all patients are equal, not all tumours are equal, either in terms of histology, and we know that some cancers shed more DNA than others, and probably those that shed, I'll show a little bit later on, are probably associated with a worse prognosis. Something about the tumour biology. I tried to highlight at the beginning with my little PowerPoint squiggles that not all abnormalities are equal, but you're quite right. It not only depends on the type of abnormality, but also the gene, its size, whether it's mutated in key areas such as hotspots, or whether it's mutated across the gene. This is an incredibly complex area, but I started doing this 20 years ago, where we were just looking for single genes on cfDNA, and where the technology is, and I'll show you in a minute or two where the technology is going. It's amazing to think about what we can do now compared to what we could do 20 years ago is just unbelievable. And the fact that we're starting to talk about doing this routinely in the NHS setting.
And then last question in the chat before we move on. Dr. Seth, do you want to ask the question yourself?
Hi, sorry, it's a very basic question. How does the plasma first approach help in cases where it's not a biopsy proven lung cancer? So if there's a possibility of, say, metastasis and it's not proven on biopsy which type of cancer it is, how does that plasma first approach help? Thanks.
Yeah, so the short answer is it doesn't always. If you have a standard EGFR mutation, like I showed that patient, you got a lung cancer, all fits with the context, you can treat it. But if you get a P53 abnormality, even at 10-15%, you can say this patient has cancer. It's got cancer, but P53 is found across all different cancer types. You can't say. So in the plasma first approach, we are still encouraging for biopsy. Sometimes the other thing it can be helpful is sometimes we'll have like an 82-year-old lady who's got other health problems. She's probably got lung cancer. She would only ever accept a tablet, and we say to her, well, you've probably got lung cancer. We do the blood. We demonstrate a profile, like I said, P53, but no treatable abnormality, nothing I can give a tablet to. And a number of those patients will then say, thank you very much. I'm not interested in having a formal biopsy. I know I've got lung cancer. You can't offer me a tablet. I'm quite happy to either have some radiotherapy or just spend time away from my family. And so that can save resources for the NHS, but also save patients going through biopsies. And we found that in our pilot that about 10% of patients choose not to have a biopsy if they have a valid result. Equally, about 10% of patients we think have lung cancer will turn out not to have lung cancer. Either they'll have small cell or lymphoma or something else. So we do occasionally get shocks, but it's still that's part of the pilot approach, is finding how often that happens.
Thank you.
Okay.
Thank you. We'll move on.
Yeah, the next bit is significantly shorter. You'll be pleased to hear. I'm certainly pleased to hear because my voice is already starting to run out. So this is about some of the new ways that we may start to do this. So I touched on this at the beginning. So what about using circulating tumour DNA to monitor response? And I briefly saw something come up in the chat on my iPad about immunotherapy and complete response and stuff like that. So people are starting to do this, and it is a valid use as the technology gets better. So this is a number of patients on immunotherapy. So if you have higher levels of circulating tumor DNA at the beginning, you're likely to do worse. But actually, if you have high levels and clear the ctDNA, you actually do quite well. But if you have high levels and you don't clear your circulating tumor DNA on immunotherapy, you can tell these patients are not going to do well. So, and this was done, I think, at about 4 or 6 weeks. So you can look relatively early on to try to work out whether your patient's responding to treatment or not. And certainly those of us who treat lung cancer on immunotherapy, it can be very challenging to interpret scans at that point. And these are expensive drugs. So, you know, we talk about the cost effectiveness, but, you know, immunotherapies cost several £1,000s a dose. And if we can avoid doing them, not only do we get patients onto different treatment, potentially ones without side effects, but we can also, again, save the NHS money by not giving expensive, futile treatments. Nerdy stuff, you can start to monitor how patients respond to treatment. So this is, again, lung cancer. It's patients on an inhibitor for KRAS and looking at using circulating tumor DNA to see how often they become resistant through different pathways. You can start to track it and work out which pathways become more important. And this is the sort of really sexy thing that gets you into the New England Journal. This is the patient that's got a rare form of lung cancer with an ALK fusion in it, and you can also sort of see the levels going up and becoming resistant on their first treatment, the green one, the ALK inhibitor, and then staying up as they change to another treatment that didn't work. And then you give your yellow treatment, your lorlatinib, and it goes down again, but then it starts to become resistant, and you can give chemotherapy and knock it back down again. So you can really start to track the patient's treatment history through their various treatments if you want to. And then, so I think this is a really nice example of where we might be able to use this techniques in the future. So this was presented at ASCO last year, and was a study called, I can't remember what it was called, and somebody's trying to phone me, which is really irritating. But it was in stage 2 colorectal cancer patients where you can be offered chemotherapy, but it's not always clear which patients should. So it hasn't spread to the nodes. Some patients have higher risk features and some don't. So what they did was they took patients, and in a third of them, they just offered standard management. The clinician and the patient could choose to go forward with the chemotherapy or not. And in the other 2, they did circulating free DNA analysis, and if they were positive, they recommended chemotherapy, and if they were negative, they didn't. And so what you can see is that there was no difference in the survival in terms of two years out, very similar survival, but you were able to about half the patients who needed adjuvant chemotherapy. So using a very simple blood test to just help guide patients and clinicians as to the best treatment. And then the 2 last bits I want to talk about is using methylated DNA, which is an emerging area. So rather than looking for mutations, looking for methylation patterns on the DNA, which start to change very early on in cancer being formed. And so this company is now looking at doing this, including a company some of you may have heard about called Grail, where they try to measure methylated cfDNA. And so this was a study run in the UK where they looked at patients who were being referred to early diagnosis centres. So these are patients where the GP is worried about them. They've got a symptom, they're losing weight, they don't look so well. And they look for methylated cfDNA. And so if you look at the black dot, 6.7% of these patients who were referred by their GPs actually ended up having cancer in the long run, which is actually a pretty good pickup. It's higher than 2-week wait. Okay. But if you did the blood test on them and it was negative, their chance of having cancer dropped to 2.4%. Okay, so you could be pretty reassuring, not completely reassuring. If a blood test was positive, then there was a 75% chance that they'd go on to be found to have cancer. So just by doing a simple blood test at the time where they came into this early diagnosis centre, and patients who already have symptoms, the GPs are worried about them, you can either hopefully partially reassure them on your GP, or actually really mount up the concern and say, I think this patient does have cancer. And the other thing about this is it gives you a potential site of origin. So it says, not only do we think this patient has cancer, but we think this patient has bowel cancer. So you can send them to the appropriate clinicians to start their workup. And they've also looked at this, and this is a very complicated slide. I'm not going to go into all of this in the screening setting. So this is a 6,000 patient study, but there's a bigger one now going on called Gallieri. In fact, I think it's just finished recruitment in the UK, looking at asymptomatic patients. And in sort of this, here they presented the data on 6,000 odd patients. They found a positive cancer signal in 100, so it's a relatively rare event. About half of those did eventually turn out to have cancer. The other half didn't, and it's from cancers from a number of different sites. So to me, this technology isn't quite ready for real time. You can't be telling 50 people that they might have cancer and sending them for investigations, but it does show the potential to pick up patients early. And in fact, we had a patient on this study who we picked up with melanoma, where the thing said, we think this guy has melanoma. So it can help detect cancer early on. And lastly, what Pasquale and I spend a lot of time doing is using circulating free DNA for study entry. So we have our patients coming forward. They send to us from clinicians. They've used up all their standard of care options. Can we do molecular profiling to try and identify new trials for them? And the short answer to this is maybe. We find a treatable abnormality in maybe 20-odd%, maybe less, depending on what profiling they've done before. But the real issue is trying to find the right studies to match them up to. So we're taking part in Target National, where patients who come to us, we take a blood sample and we send it off. We get the results back 2 weeks later. So I think Pasquale and I had 8 come back this morning, and then we look at it and trying to work out whether that can line them up to trials or not. So that's where we're going with cfDNA. We're moving it into the trial setting to try and help patients on the trial, but particularly moving it to that earlier setting in patients who've either had surgery or radiotherapy, trying to work out if those that need future management or not, and coming forward even earlier, looking at those patients who are not yet diagnosed with cancer to try and pick them up earlier. So that was very quick. So just to conclude all the stuff I've said, look, this is a really valuable tool in our toolbox, but it is not a panacea. It doesn't tell us everything about the patient, and it's got huge potential in terms of its rapid, results in 1 to 2 weeks, gives us an up-to-date picture of where our patient's up to on DNA. But there are problems in terms of sensitivity, particularly as you move out of a late stage setting, false positives, and it cannot replace tumor biopsy. These both give important information in terms of how to guide the care of our patients. So hopefully that has been at an appropriate level, and I'm happy to take any questions about that second part or anything else that I said in the first part that people have thought about.
Thank you very, very much. There's a question in the chat from Maria. Maria, are you still online? And we can ask that. Do you still want to ask that question? So basically what Maria has asked from is, so from what you say, it sounds as though cfDNA may not be very sensitive to follow-up patients in complete response after immunotherapy. Are we looking at whether it is more sensitive than CT scans, and at what point might it become more cost effective than scanning patients for years?
Yeah. So the short answer is it may be. It does get a bit complex here. So in an ideal world, so the best thing would be what's called a tumor-informed assay, and people aren't really doing those except through research. So where you profile your patient's tumor, and then you can design their own assay and follow their own tumor, and that's actually very, very sensitive for picking up minimal residual disease and relapse, to the point where you could use it for something like saying they're in complete response because you can't detect it, and then following them up. And that certainly might be better, maybe not more cost effective than CT scans, but might pick it up earlier. Unfortunately, the practicalities of doing that and the cost of doing that at the moment are very challenging. So what in general is being done at the moment is 200 or 300 gene panels. And there you do start to run into the problems of sensitivity. If you're looking for 300 odd genes, that you struggle to get down to the sort of below the 0.1%. I think if you think a patient's in complete response, but you're still picking up tumor DNA, that suggests they probably aren't in complete response. That tells you that there's still probably active cancer somewhere. But if there isn't tumor DNA, trying to extrapolate that and saying that your patient is in complete response, I don't think we're quite there yet.
Okay, thank you. And a question from Rosalind Bradshaw.
I've kept this one quite easy, Alastair, so don't worry. Just really, in terms of, you mentioned with Target National, there is a national tumour board. As you go into commissioning for lung from April, do you see that this could be something that is rolled out nationally to support clinicians making decisions from the reports?
Yeah, it's something we're looking at to to try and think about whether it should be national. I'm actually a little bit against that. I think there's probably enough work for us to do it regionally and to adjust our genomic tumour advisory boards. The other thing is that, and certainly we've found this in the pilot, so when we started doing this 2 years ago, every single report used to get sent to me because people weren't used to seeing them. And I think I've said this to you before, I think there's a learning curve about the first 50 to 100 reports that you look at once you get used to interpreting them. And so then I found about 3 months in that people were sending them to me and saying, well, we think this, is this, do you agree? And I'd be like, yeah, most of the time, yeah, completely agree. Occasionally I say, no, actually, maybe there's a bit more nuance than that. And nowadays, actually, most of the lung cancer oncologists in the Northeast don't even bother sending them to me unless it's a weird and wonderful. They're quite happy to just use the results. It's become part of their day in, day out job. They've been doing it for a year. You get used to them. And so then the need for Genomics Tumour Advisory Board to look at all of these goes down. So I don't know if that answers your question, Ros, but I'm hoping that it might just be the Northeast and that we can keep it amongst ourselves.
Thank you.
Thank you. We've got about 5 minutes if anybody wants any other questions answering, or we can give you back 8 minutes of your time. I think that might be it.
I'm released. I'm relieved.
I guess on behalf of everybody, thank you very much. A fascinating subject, and I think by the interest, I think it was well worth doing. So yes, thank you very much. I am just going to hand over to Jim for a moment, just before we close, to tell you about our March webinar, and how you register in the usual way. So Jim, are you there?
I am here, and now it's my turn to see if technology allows me to share, but hopefully this will be quite straightforward. So is this working?
We're waiting with trepidation, Jim.
Not as much trepidation as I am if I pick the wrong tab. Yes, there we are. So next month we'll be very pleased to welcome Professor Sir John Byrne to talk about his work on Lynch syndrome and genomics. Some of you will have seen today, it's quite I didn't time this, but it's very helpful that announcement around a new screening program for Lynch syndrome has come out today. So yeah, hopefully very timely, and again, Professor John comes with a huge amount of experience in this field, and we're talking about not just his own sort of journey through this, but also what best practice and what the future looks like around Lynch syndrome and its interaction with genomics. So you can use this link online, which hopefully, if you can use that QR code, then that will allow you to share. But I'll also just pop the registration link in the chat now, if you want to click through and you can register. And I should also just say that we will be sharing out the recording of this session within the next few days. A little bit of editing to do, and then it'll be free both on Northern Cancer Alliance and NEYGMS's website for your use. So I'll leave that slide up, and just in case anyone is trying to use it. And yes, hand back to Nikki.
Okay. So all I need to say is thank you to Professor Greystoke for the last hour. Really, really informative. And by the feedback we're getting in the chat, everybody did really find it valuable. So thank you, and hopefully see you in March for the next webinar. And thank you very much. And we've given you 5 minutes back, so that's not so bad. And enjoy the rest of your day. So thank you.